Hello, everyone. This is Dr. Jaafer Golzar coming to you from Chicago. I want to welcome you to NCVH Digital Education Series. I want to really thank Dr. Craig Walker for inviting me again this year to NCVH. Unfortunately, we're not there to join him in New Orleans, but Chicago will have to do virtually this year. And I want to also give a shout out to the minds behind this digital education series, Tom Bess and Jonathan Meyer, and really appreciate all their hard work and their team's hard work that work in the background diligently to really bring this educational series to you guys. So today I was asked to speak about intravascular imaging in peripheral arterial disease. This is a topic that's been really hot and really an important topic over the past several years as technologies and intravascular imaging technologies have advanced. So as you all know, we've had significant advancements in the treatment of peripheral arterial disease, but not only is this the actual therapeutic devices, which we really focus on very often, but also advancement in digital imaging, because if it wasn't for minimally invasive digital imaging, we really couldn't do what we do in the cath lab and endovascular suites. So as you know, the evaluation and treatment of peripheral arterial disease is really dependent on accurate imaging. Intravascular imaging helps us in improving accuracy by evaluating equivocal lesions, which may be underestimated by angiography, evaluating eccentric plaques. Think about plaques that have mostly posterior origins, and it's really hard to see those in an AP setting, and also to evaluate vessel diameter. In addition, intravascular imaging can give you objective evidence of plaque morphology, and understanding this plaque morphology can help you improve your outcomes by changing the type of therapeutic devices that are used for treatment. Now, when we look overall at the comparative analysis of imaging, it's a double-edged sword when we look at vascular imaging as well as medical imaging in general. So as you increase penetration depth, as you can see more and more of the vessel or more and more of the patient, you're going to decrease the resolution. And this is true for microscopy, OCT, ultrasound. As you increase the depth of what you're able to see, you're going to decrease the resolution. And that's an inherent issue that we see with any type of imaging modality. So traditionally, we've used angiography, and we're all familiar with angiography. This has been the mainstay of both cardiac as well as vascular imaging, injecting contrast into the blood vessel, as you can see on the far left. Now, this is, as you can imagine, an external view of the vessel, and this brings with it limitations. And as you also know, that it gives radiation exposure both to the patient as well as to the physician. However, it can be used for both diagnostic and therapeutic purposes. Now, when we look at intravascular imaging, these are the two new ones on the block. So we have intravascular ultrasound as well as OCT. Now, both of these look at the vessel from inside out. So you can actually see what's going inside of the vessel. There's no radiation exposure. Intravascular ultrasound can be used for diagnostic purposes and limited therapeutic purposes, mostly for reentry when we use the Pioneer device. And OCT is used for both diagnostic and therapeutic purposes. Now, as we'll discuss a little bit later, OCT has much higher resolution than intravascular ultrasound, but as we discussed before, this will decrease the penetration depth. So let's talk about the clinical data associated with angiography versus intravascular imaging. So we talked about the theoretical advantage. What's the data behind this? Well, there's a study called the Arthur study that enrolled 93 patients prospectively, and it was an observational study, and it looked at intravascular ultrasound and compared it to angiography. And really what it showed was that angiography overestimates the amount of calcification that we see in vessels. So it was estimated to be 40% by angiography and only actually 7% by intravascular ultrasound. The LEADER study evaluated intravascular ultrasound for femoral popliteal stenting, and it showed that you can actually improve primary patency at up to 5 years when using intravascular ultrasound versus angiography alone. Now, that also has been shown in the Viper study, which was a study that looked at Viabond stent implantation, in which intravascular ultrasound was used for correct sizing, and they showed improved patency when Viabond stents were implanted using intravascular ultrasound sizing versus not using IVUS sizing. Furthermore, as you all know, DCB is really contingent upon the anti-restenosis effects of DCBs is really contingent upon accurate sizing, and intravascular ultrasound can help with vessel sizing in those situations. Furthermore, when we use intravascular imaging, we can help on evaluating plaque morphology, evaluating thrombus vessel size, and really help evaluate the next step and what we should be using in our treatment algorithm in treating those vessels. Furthermore, we can also use it post-treatment to see, have we adequately treated the vessel? Have we adequately expanded the stent? So there's a lot of use in intravascular imaging. So let's do a deep dive in intravascular ultrasound and OCT. So IVUS uses sound waves, and sound waves are emitted from the actual transducer. And these sound waves are then reflected back in different densities, reflect in different manners. And this is how we then get the image on our screen from intravascular ultrasound. Now, on the other hand, OCT, or optical coherence tomography, uses the same type of concept, but instead of sound waves, uses near infrared light and scans the artery in a similar way. And based on the different densities, the image is reflected back and then shown to us on the screen. However, it does give us a higher resolution of up to 10 microns compared to ultrasound, which gives us a resolution of about 100 microns. So when we look at intravascular ultrasound, there's two types of intravascular ultrasound. There's mechanical as well as solid state. So mechanical ultrasound is actually when the ultrasound is housed within the catheter and it actually rotates within the catheter itself. And there's advantages to disadvantages of this, but there's an external guide wire and there are moving parts. Now, this is the one that's actually made by Boston Scientific, as you guys know, and there's multiple different sizes that will be able to visualize multiple different vessel sizes, including coronaries, peripherals, as well as intracardiac echo. Now, the solid state or phased array intravascular ultrasound, instead of having a moving part, there's actually a single mechanism inside of the ultrasound that actually acquires the image one at a time as it goes through and spins quickly and activates each ultrasound device within the catheter itself. There's no moving parts, but that's how it actually records the image. And there's a central guide wire lumen. So some advantages, as I mentioned, and disadvantages in terms of trackability and pushability of the catheters, but really minimal. So these are the devices of the phased array ultrasound that we see. There's 014, 018, 035. So 035 can be a great addition to use for venous imaging, for aortic imaging. And there's a Pioneer Plus, which I mentioned before, which is the IVUS guided reentry catheter. It's a sort of a therapeutic catheter, not really, basically allows you to re-enter into the true lumen with the side needle, but you can actually see exactly what you're doing versus the Outback, which is a similar reentry device, but no intravascular imaging to guide you in your reentry. So let's compare intravascular ultrasound to OCT. As I mentioned before, advantages and disadvantages to really all technologies, and OCT and IVUS is no different. So when we look at IVUS for PAD, much higher penetration of ultrasound. As we mentioned before, you can see large vessels like the aorta, you can see the IVC, you can see iliac veins. You're able to visualize through blood. There's a technology called CHROMOFLO that allows you to see the blood flow, as well as a virtual histology type of software upgrade that I'm not sure if it really personally provides a lot of advantage from my standpoint, but maybe some people find it useful. It can be used for vessel sizing. It's widely available, especially in OBLs and cardiac cath labs, because in the cath lab, we use this frequently in the coronary vasculature as well. One major advantage is there is reimbursement for diagnostic imaging, and that's why we've seen really one of the reasons also we've seen an expansion, not only because of physician comfort level with the imaging, but also our ability to be able to reimburse and not waste the hospital resources without any reimbursement. The disadvantages is the resolution is much lower than what we see with OCT, and the penetration through calcium is much less than what we see with OCT. So now let's go to OCT. So the advantages, as I mentioned before, much higher resolution than intravascular ultrasound, much better penetration through calcium as compared to IVUS. It can be used for both diagnostic and therapeutic purposes. You can use it for vessel sizing. It's not as widely available as a technology as intravascular ultrasound, and less physicians are knowledgeable of OCT interpretation because there's a lot more information that they're gaining, and you have to really understand what we're looking at. And we're going to show some images to really kind of give you an indication. But once you get comfortable with what you're actually looking at, then I think the physician knowledge and experience goes up tremendously. In terms of disadvantages, it doesn't do well through blood. However, when we look at chronic total occlusions, it's crossing through chronic total occlusions. There's no blood flow, so it's helpful with that. Or if there's severe disease that you're treating, there's really not a lot of blood flow, so it really is less of an issue in those situations. Less penetration depth than intravascular ultrasound, so really the sweet spot is 2 millimeters to 6 millimeters, really above 6 millimeters, the penetration depth is not going to be as good. Currently, there's no reimbursement for diagnostic purposes only, but that may change in the future. And again, as I mentioned, it's not as widely available as intravascular ultrasound. So let's talk about the comparison, what studies are available that compare intravascular ultrasound with OCT. So there was a study that was published in 2013 initially that looked at a comparison between OCT as well as intravascular ultrasound and looked at image quality, and it showed that OCT provided much superior image quality in looking at vessel walls, layers, and different plaque components. Now, a more contemporary study was one that was published this year called the SCAN study. And this was a study that evaluated 12 patients. And essentially what they did is patients that were undergoing procedures, they basically put down an IVUS catheter, did a pullback, and then put down an OCT catheter in the same segment and did another pullback, and then randomized those images and had physicians that were blinded evaluate these, and based on a point system, they looked at layered structures, non-layered structures, calcification, stent structures, and artifact, and rated them from excellent to poor on each one. So what do we mean by some of these names? So when we talk about layered structures, where we're talking about the intima, the media, the adventitia, the important things that we look at when we're looking at vessel lumens and vessel walls. So on the left-hand side, you see the intima, which is closest to the lumen, then the media, which is this thick muscular layer, and then far field is adventitia. You see a similar situation on the OCT image on the right, which intima is the first layer, number 1, media is the second layer, number 2, and 3 is the far field is adventitia. Now, when we look at this histologically, you can see in the far left, the intima histologically is this very thin layer, the top layer of the vessel wall that touches the lumen, and you can correlate it to the OCT imaging that you can see in the middle and on the far right. And as you can see, much higher resolution than what we saw with the IVUS, but really, really close to what we see histologically. So in terms of non-layered structures, it's pretty much everything else. So plaque, calcium, stents, things like that. So those are the non-layered structures. So on the left-hand side, you see an OCT image of non-layered structure, which is actually plaque around 9 o'clock. And then you see a similar structure on the right-hand panel, which is a non-layered structure. And this is the match images from the scan study. And this is sort of what they were, the independent readers were looking at, were these matched images from OCT as well as intravascular ultrasound. So again, calcification comparison. On the left-hand side, you can see what calcium looks like. As I mentioned before, this is one of the downfalls of intravascular ultrasound, or any ultrasound, is calcium, because we see shadow artifact. Calcium sound waves cannot pass through calcium, so they're reflected back, and you see the shadowing behind calcium, whereas OCT and infrared light can pass through that. So you see much higher resolution and much clearer definition of calcium with OCT. So again, matched images, as you can see on the left-hand side of calcium, as well as on the right-hand side of plaque. So what did the scan study showed in terms of layered structure? The difference between IVUS and OCT was not statistically significant in interpretation. Non-layered structures, meaning plaque, OCT was better at evaluating those, and this was statistically significant. Value in calcification, OCT was better, and stent struts, OCT better. Artifacts, no difference between intravascular ultrasound and OCT. So this is calcium, as I mentioned before, one of the Achilles heels of what we do in the cath lab, both diagnostic and therapeutic, in terms of endovascular. So this is really what calcium would look like under intravascular ultrasound: bright white hyperechoic structure, and you'll have a shadowing artifact behind that, as you can see, and this is correlating to the angiography on the left. On the middle screen, you see a similar situation of heavy calcification, boulder type lesions with minimal luminal, with significant luminal penetration and a small lumen there. As you can see on intravascular ultrasound, you see calcium here around 12 o'clock and shadow artifact behind that, but that's what tells you that this is calcium, in a similar situation on the right panel. And then, as we mentioned before, just some more images of what we see with OCT. So you see at 6 o'clock, you see calcium, you see the shadow artifact. But again, the shadow is what tells you that it's actually calcium. With OCT, because the infrared light actually passes through the calcium, you see have a little bit better penetration of that, and a delineation of what the lake of calcium looks like. And here you can see media and calcium infiltration into the media itself. So again, another example of a nice lake of calcium within that structure. Here you see live imaging of what we actually see when we're doing PULVACs and evaluating OCT as well as intravascular ultrasound. So you see basically plaque here and the device moving, and you see media, thick media here, nice clear delineation and far field here. You see adventitia. Here you see the media here, as well as some calcium at around 12 o'clock. You see that shadow artifact. This is a nice example of the CHROMOFLO, which is the blood flow that I described previously, that shows that there's blood flow throughout this lumen, and that's shown in red. But then you see that plaque really circumferentially around that IVUS catheter as there's a pullback taking place. This is an example of what stents look like. And so by intravascular ultrasound, by OCT on the left, you can see significant plaque, collagen plaque, fibrotic plaque in that vessel, and you see the stent struts here. So that's really what you're really looking for, is those bright segments. That's what shows you that there's stent struts. And then by intravascular ultrasound, a similar situation where you see those bright segments, and that is the stent strut. And further delineation of more morphologies. Now, this talk is really not meant to cover all of what we can see by intravascular imaging. There's so much that we can see, including necrotic core, lipid pools, but really this is outside of the breadth and depth of this talk. But just a cool image is what we can see. Another thing that we see on intravascular imaging is dissection flaps. And here you can see by intravascular ultrasound, a dissection flap, as well as a CHROMOFLO around that. Really, that helps you point that out a little bit better. Here's another dissection as that plaque is coming off. This is a plaque dissection, so the plaque is actually being peeled away like an onion from the vessel wall, and another plaque dissection, as we can see here, after atherectomy. And most likely, that's actually a piece of plaque that's extending into that vessel lumen. Now, here's an example of a dissection flap by OCT. As you can see, it's kind of peeled away that plaque from the vessel wall. This is media, far field is adventitia. But the nice thing with that is, as we mentioned, therapeutically, you can, in a live manner, not only see the dissection flap, but with this atherectomy device, OCT-guided directional atherectomy device, you can actually shave the plaque out as you see it and actually remove it and really negate the need for using a stent in this situation. As we mentioned before, CHROMOFLO is helpful in these situations. And this is a coronary example where you've deployed a stent, but it's poorly opposed. And so you can see there's flow around that stent. You can also see things like necrotic core. This is a software evaluation of where it looks at different densities and it processes that image. Again, a little bit more challenging for me personally, but maybe some other physicians have used this to more of their benefit. But I feel like OCT maybe get a little bit better resolution, and you can see this a little bit more, but again, I believe that's for another talk. One of the most important things that I believe is really when we do atherectomy is not damaging the adventitia, not damaging vessel wall. And with intravascular imaging, it really allows you to see what kind of damage you've done, and hopefully not any damage at all if you're using OCT-guided directional atherectomy, and really being able to avoid any adventitia or medial cuts. But here's an example of atherectomy cut right up into the media here on the right, and really without disrupting any adventitia. Here there looks to be a cut deep into the adventitia by OCT, and by intravascular ultrasound also we see a similar deep adventitial cut. So really intravascular imaging is so helpful in these situations, because it really allows you to see what type of, how deep you've gone into the adventitia, and it maybe allows you to change your treatment algorithm, maybe be more aggressive anti-restenosis therapies, because we know when we disrupt the adventitia that we're going to incite restenosis. So in summary, intravascular imaging can help by improving grading of calcium, has been shown in studies, by improving the evaluation of plaque morphology, aiding in proper device selection, and improving short and long-term patency. Both intravascular ultrasound as well as OCT imaging have advantages as well as limitations, but overall add a significant amount of useful information to help us guide therapeutic options in the treatment of patients with peripheral arterial disease. Thank you again to the NCVH team for allowing me to do this talk, and as well to Dr. Craig Walker. Thank you very much, and until next time, see you later from Chicago. Thank you.